Hello, everybody. I'm just doing a recording because I won't be with you on Monday the 5th. So, this is to take the place of that. So, if you could try and get the work done that I'm setting out in this recording by the time we meet again on the Monday after half term, that would be fantastic. So, I've put up on Canvas all that you need to know for last week and this week. So, hopefully, you'll be able to be completely up to date. So the aim of this week's work is to start on the worksheets that's in the manual. I'm just getting your lovely sports a massage manual, and we're going to start completing the worksheets, quite a big worksheet that starts on page 8, and we're going to go from page 8 to page 11. Now, I've already made a PowerPoint that you could have a read through and make notes from in order to fill in these sections, but I thought I'd also do a video as well for those who prefer to write while I talk. So this is a slightly abridged version of what I did on the PowerPoint. So just to say, as well as doing this, I'd like you to have a look at the shoulder girdle complex, especially looking at the bony landmarks of the scapula. I think that's the most important thing. But basically, any revision you can do from your level 3 shoulder girdle will be fantastic. And as I say, if you can look at the bony landmarks on the scapula so you feel you really know that, that would be brilliant. I hope you all got on well with the spinal stuff from last week. So let's get cracking. So if you can turn to page 8, I'm going to actually read out some of the answers that I've got. You can either write them directly if you want, or you can have a listen and then write them up in your own words. But I want you to fill in the worksheet as you go along. So you'll need to pause the recording and maybe replay it if you miss. I'll speak fairly slowly, but yes, you'll need to kind of go back to make sure you don't miss anything. Okay, so I hope you've got pen and paper ready. Let's get going. So question 8, page 8, first question. Define a dermatome and a myotome. Dermatome first. A dermatome is an area of skin supplied by a single spinal nerve. Myotome. A myotome is a group of muscles innervated by a single spinal nerve. Number 2, what is the purpose of dermatome testing? So dermatome testing is done to assess if there's any sensory changes at a particular disc level, such as tingling or numbness or diminished sensation. And results may indicate if specific spinal nerves are lesioned, diseased, or injured, or if there's been some intervertebral disc herniation. Number 3, what is the purpose of myotome testing? So myotomes are testing for muscular strength at a particular spinal level. And again, results may indicate if specific spinal nerves are lesioned, diseased, or if there's been an injury, or if there has been an intervertebral disc herniation. Hope you're catching up. Hope you're keeping up. So question number 4 is the 4 pathways of the peripheral nervous system. So we're going to do the different plexuses or plexi, I'm not quite sure. So we're going to look at, for A, B, C, and D, we're going to be doing the cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. And just so you understand the terminology, I'm sure you do, a plexus is just a web of nerves that's created from groups of spinal nerves. So we're going from the top of the spine down, and they each sort of form into these 4 main groups. So firstly, our cervical plexus. So this is a nerve plexus of the anterior rami of C1 to C4. It supplies motor innervation to structures in the neck and trunk, including the diaphragm. and sensory innervation to parts of the head, neck, and chest. B is the brachial plexus. This is a bundle of nerves that stems from nerve roots C5 to T1, creating a network that connects to the nerves in the arms. It supplies efferent and afferent nerve fibers to the chest, shoulder, arm, forearm, and hand. So, turn over the page. Lumbar plexus next. So, the lumbar plexus is a collection of nerves that's created lateral to where T12 to L5 exit the spinal cord. It supplies the skin and musculature of the lower limb and pelvic girdle. It originates within psoas major, and its branches include the obturator and femoral nerves. And then D, we're doing the sacral plexus. So this is formed by the nerves from S1 to S4, and it's located on the surface of the posterior pelvic wall, anterior to the piriformis muscle. It provides motor and sensory nerves for the posterior thigh, most of the lower leg, the entire foot, and part of the pelvis. So those are our 4 plexuses. So number 5 now is describe 4 common causes of neurological damage. I've put loads of different ones on the PowerPoint, so I'll just read out a few here. So the first one is hereditary, and common genetically inherited neurological disorders include Alzheimer's, Parkinson's, epilepsy, Huntington's disease, dyslexia, autistic spectrum disorders, and amyotrophic lateral sclerosis. You can, if you want, just put ALS, but it stands for amyotrophic lateral sclerosis. So that's A, hereditary. B is acquired. So these are neurological impairments caused by trauma, exposure to toxins, injury, infection, metabolic or inflammatory disorders. These impairments can include cognitive and swallow and communication impairments, and are common following stroke, brain trauma, and various neurological diseases. C is injury. This is neurological damage that occurs as a result of a fall or sports injury. It includes compression, crush, and severance injuries, and includes paralysis. So last one for number 5 is medical conditions. So there's a wide range of medical conditions that can result in neurological damage, including diabetes, celiac disease, kidney disease, multiple sclerosis, cancer, Lyme's disease, and the herpes zoster virus. So that's the 4 common causes of neurological damage. Now we're going on to number 6. Describe each of the following common peripheral neuropathy patterns. So the first one is sciatica. You're going to have to write fairly small for this, okay? So this is radiating pain along the sciatic nerve, causing posterior leg pain that radiates from the lower back or buttock, down one or both legs. It is often associated with myotomal weakness and dermatomal paresthesia below L4. So just to check, when I'm saying myotomal weakness, you understand this is not to write down, but remember I said at each level the spinal nerves control a certain group of muscles. So it's saying you have a specific group of muscles linked to where the damage is in the spine that you'll find are weak. And again, the dermatomal paresthesia, you'll have an area of numbness that relates to the dermatome pattern of the spine. Okay. So B is lumbar radiculopathy. So this is pain in the lower back and hip that radiates down the back of the thigh into the leg. It refers to any neuropathic leg pain and can include a range of symptoms, including numbness, paresthesia, loss of motor function, and pain. So the important thing to remember for this one is it's a range of symptoms. C is carpal tunnel syndrome. So this is where the median nerve is compressed as it passes through the carpal tunnel and can cause pain, numbness, and weakness in the thumb, index finger, middle finger, and the radial side, so half of the ring finger. So if I said that right, thumb, index, middle, and half of, so this half of your ring finger. So that's the median nerve distribution. So D is the ulnar nerve compression, also known as cyclist's palsy. So you don't have to write this down, but it's because it's fairly obvious where the pressure down on the handlebars causes damage to the nerve. So this is where there is pain, numbness, tingling in the ulnar side of the palm. So here we go. So this time we're looking at this side of the palm. So here, the little finger and the ulnar side of the ring finger. Okay, so that's this half of the hand now for the ulnar nerve, caused by pressure on the ulnar nerve. This can also give muscle weakness in the hand. I'll read that again. I don't think I did a very good job there. This is where there is pain, numbness, or tingling in the ulnar side of the palm, the little finger, and the ulnar side of the ring finger from pressure on the ulnar nerve. There can also be weakness in the hand. That was better. Okay, E is perineal numbness. So this is also known as saddle anesthesia and is where when there is little or no sensation in the perineum, possibly also affecting bladder, bowel, and sexual function. So that's number 6 completed. Make sure you get all that down, pause the video, go back over it if you need to, and get that all finished on paper before we move on. Great, so number 7 now. So it says complete the following table by describing the following neural presentations that warrant neurological testing. So let's work our way down. Firstly, radicular pain. So this is a kind of pain that radiates from the back and hip into the legs, caused by compressed or inflamed spinal nerves. It has only pain as a symptom from the nerve root. It's because I crossed all this stuff out. Let me try that again. Sorry. So this is a type of pain that radiates from the back or the hip into the legs, caused by compressed, inflamed spinal nerve. Radicular pain is where there is only pain as a symptom. So if you remember, I said for lumbar radiculopathy that's got very similar symptoms, but it can have a similar sounding presentation, but that has a whole range of symptoms, lumbar radiculopathy, whereas radicular pain, it's just pain, okay, down the leg. Okay, secondly, paresthesia. This is where there's abnormal sensation, such as tingling, numbness, and pins and needles. That's pretty straightforward. Loss of sensation is just numbness in any area. Another easy one. Muscular weakness and flaccidity. So this is where there's peripheral nerve weakness isolated to a particular nerve, not a global presentation. Flaccidity is the loss of muscle tone where the muscles are floppy and soft. E, positive straight leg raise. A positive straight leg raise is where pain is reproduced through passive flexion of the lower limb and sensitized by foot movements. That means you can provoke the symptoms on and off by adding in foot flexion extension. Pain reproduction between 30 degrees and 70 degrees is suggestive of L4-S1 lumbar disc herniation. If you've got any questions, do just write them down on a bit of paper, and when we meet again next, I'll go through anything. Okay, so we're now final little bit. If you can turn over onto page 11, and it says, why is it important to refer a client for neurological testing on presentation of symptoms? So 3 main points for this. To ensure the practitioner works within their scope of practice. To eliminate or confirm and receive urgent treatment for neurological disease or injury, and to reduce the risk of long-term complications. So I'm going to add another one in. To be able to identify red flags indicating the need for emergency referral. Okay, so I hope you've managed to kind of catch up on what I was saying and fill in all of those boxes. And then we've made really, really good progress already on our worksheet. And next time we're going to go on to looking at the medication. But from after half term onwards, I'll be with you every Monday. So apologies once more for not being with you in person. And I really hope you can spend that time profitably getting that worksheet done, starting to look at the shoulder and just swatting up on any of the spinal stuff that you're not sure about. We will go through things again and have a chance to answer any questions. All right, take care. All the best. Bye bye.